It's my pleasure to introduce our next speaker, Emmanuel Menga. He is a professor of orthopedic surgery at University of Miami and the program director there. He's going to be speaking about management of spinal deformities associated with osteoporosis.
Hey, good morning, everyone. I think Lionel pushed my talk to today so he can keep me in the room last night. Thanks, Lionel, Kyle, Lee, for an excellent meeting, and thanks everyone for coming to another outstanding program. So this is looking back in 2019 when this all started. And as I mentioned last year, we all showed up in suits and jackets, and now everyone is running around in Hawaiian shirts, so it's pretty good to see that. I have no relevant disclosures related to this topic. So going over learning objectives. So the goal is today, the goal is for everyone to understand spinal deformity, at least have some understanding of spinal deformity, understand what osteoporosis means, the clinical implications of osteoporosis, especially in relationship to spinal deformity, adult spinal deformity to be more specific, not to ignore the fact that some pediatric patients do have osteoporosis. Management of osteoporosis, medical management, and also the surgical approach when you look at patients with osteoporosis who require surgical intervention or considerations for surgical intervention. So I think most of us, some of you have seen patients like this in your clinic, either come in as your primary patient with failed surgery with proximal junctional failure or proximal junctional kyphosis, or see patients like this as a revision surgery from other surgeons presenting to your clinic. You see an example of a patient with a previous lumbar fusion surgery, developed PJK, underwent. You can see this is an example of a case I collected during residency. Underwent pedicle subtraction osteotomies to correct the alignment and then failed at the top, and the patient ended up with occipital pelvic fusion. So I'm sure most of you with experience have seen this. You've also seen patients like this. So this is a patient with a CD construct, the Cottrell-Doucet construct. And I'm sure you've seen patients like this with previous Harrington rods who develop rod fracture or I work at a level 1 trauma center, so I also deal with a lot of trauma patients who come in with previous constructs similar to this or with a previous Harrington rod and failure or fracture above or below the previous hardware, and how do you manage that, especially for some of these patients with osteoporosis because of the chronic immobilization of their bone. We've also seen patients like this who present to your clinic with radicular pain and back pain, sometimes symptomatic scoliosis or isolated lumbar radiculopathy, but the patient is not healthy. If you look at this particular picture, look at the size of a patient's heart with a pacemaker. It's like the size of a football. And is this someone who's healthy enough to undergo spinal deformity surgery, or do you address their current symptoms, isolated symptomatic management? So what is spinal deformity? I'm sure a majority of, at least majority of the people I know here, faculty and some of the attendants I know here are members of Scoliosis Research Society. So Scoliosis Research Society defines adult spinal deformity. It's a heterogeneous group. The patients with scoliosis, whether it's idiopathic or congenital or syndromic or neuromuscular. Kyphosis also could be congenital or idiopathic. Post-surgical malalignment, which we see patients who've undergone surgery, whether degen surgery or previous deformity surgery, patients with coronal and sagittal imbalance, patients with spondylolisthesis, and something that's often ignored, even patients with spondylolysis are considered patients with considered to have deformity. Again, this affects, adult spinal deformity affects about 68% of adults over the age of 60. So what is osteoporosis? We often think of osteoporosis more, especially from a surgical approach when we're thinking of deformity, more of an issue with fixation. But we also have to understand that, it's both a mineral and organic component to it. So you can develop issues with fusion with osteoporosis. It affects up to about 20 million people, and the female to male ratio is reported anywhere between 2:1 to 4:1. With up to 80% of patients with osteoporosis being females and 20% males. So it's not an isolated issue affecting strictly females. We know males also have osteoporosis. And over 500,000 of these patients suffer spinal fractures, especially working at a level 1 trauma center. I'm sure most of you see this routinely. And it's not just about treating the fracture, but what I often stress is to treat the underlying problem, which is the osteoporosis, to reduce further fractures. So 20% of these patients may experience deformity because depending on they can develop kyphosis. Depending on the asymmetry of the fracture, they can develop scoliosis. Some of these patients already have scoliosis. And because of the subsequent, looking at the natural history of osteoporotic fractures, these patients can continue to subside, whether it's coronally or sagittally, and develop kyphosis and coronal imbalance. Osteoporosis is defined as a T-score using bone mineral density from a DEXA scan of negative 2.5. And how many people in the audience, especially faculty, obtain DEXA on all of their deformity cases? Lionel, I didn't see your hand up. You don't?
I usually use opportunistic density opposite.
CT, yeah. And how many people use the CT to plan for the surgery? Okay. So we know DEXA is not accurate. It comes, especially when it comes to, is the gold standard when it comes to evaluating patients for osteoporosis. So it's a gold standard, but we know it's not accurate, especially for patients with scoliosis, patients with severe spondylosis or arthritis of their spine, and patients with previous surgery. And when you think about adult deformity, majority, maybe over 30–40% of the time you're dealing with patients who are undergoing revision surgery or they have severe spondylosis associated with their scoliosis. So it's not the most accurate study, but it's still the gold standard. So I get it on every patient who requires surgery, or even if I discuss with a patient about their deformity surgery and they opt not to have surgery, I still get a DEXA scan so we can treat their osteoporosis just in case they ever need surgery or to prevent them from decompensating from where they already, from their baseline. So a T-score of greater than -1 is considered normal, so normal bone, and it's not unusual. Sometimes you get a DEXA scan and it shows normal, and you go to surgery and the patient has the worst bone you've ever encountered. So that's why we know it's not a very accurate study. T-score of -1.0 to greater than -2.5 is considered osteopenia. And sometimes we know there's a challenge in getting an insurance to approve treatment for osteoporosis with some of these patients. But you can make the argument, especially if you're planning for a big deformity surgery. T-score of less than -2.5 is considered osteoporosis. And then the next question, I remember a few years ago discussing with Dr. Lanke when he was here as a guest speaker, and it's the same thing even if you review the literature. There's no defined guideline as if the T-score is less than -3, no surgery, or if it's -4, like where do you stop? And no one seems to be able to give you an accurate or exact information as to don't do surgery on this person because of the score, because we know some of these patients, it's a matter of urgency, and you have to make that decision. I typically try to avoid operating on patients with T-score of less than -3.0, but I'm going to show you case examples of patients that, to a certain degree, had very limited option, and the patient required something, needed something done. Lionel mentioned use of an opportunistic CT scan, Hounsfield unit, to measure bone density. We know it's still being evaluated, and also, especially for patients with spinal deformity, there have been some studies correlating DEXA scan and where's the cutoff to define a patient as having normal bone based on Hounsfield unit. 133 has been published, and 100.8 has been published for osteopenia, and 78 for osteoporosis, trying to correlate that to DEXA scan. We also know that the CT scan must be calibrated to measure accurate Hounsfield unit. So I know we all use Hounsfield unit routinely to plan for surgery, but it's still not accurate because, how often does the radiology department calibrate that machine? I remember several years ago, I can't remember if it was at IMAS or SRS, and one of the speakers was a radiologist, a CT specialist in radiologist, and he said the machine has to be calibrated on an average every 3 to 4 months. How often do you think that gets done at the hospital to get a good measurement? So even what we use as opportunistic CT is not accurate, but it gives us at least some information in addition to the DEXA scan. I'm not sure how insurance goes about approving medications for osteoporosis strictly based on Hounsfield unit. So that goes back to using DEXA as a gold standard, and consider using that because that might help your patient getting the medication approved for treating the osteoporosis. So what are the clinical implications of osteoporosis? We often think of it more as a fixation issue. So looking at it from that perspective, you have to put screws in the spine, and think about the easier way I describe it to patients is like hanging a picture on the wall. If you find that stud and put that nail and put the picture, it's going to stay there, but if you just put the nail on a random spot on the wall, it's going to fall off at some point, and that's what I try to describe to patients. So fixation failure, vertebral fractures, either at the level of the instrumentation or above the level of the instrumentation, adjacent segment failure, which can all lead to sagittal and coronal malalignment. And in some cases, because of the either coronal tilt, it can lead to foraminal stenosis, which can lead to radiculopathy. In some cases, it can lead to kyphosis, or even just the general collapse leading to buckling of the ligamentum flavum and disc herniation, or even the fracture fragment can lead to severe stenosis, which can cause myelopathy, and in severe cases can lead to spinal cord injury. We know fusion. So we know osteoporosis also decreases the rate of fusion. There's several studies demonstrating that patients with osteoporosis have an increased risk for non-union or perioperative complications. Complications including DVT, and it's a predictor. It's been shown as an independent predictor for revision surgery. Gupta at WashU demonstrated risk for hardware failure, pseudoarthrosis, PJK infection, all associated with osteoporosis. So understanding treatment for osteoporosis. So you've seen your patient, you've obtained a DEXA scan, you've measured the Hounsfield unit, and now you're trying to determine what treatment do I use for this particular patient. And if you think about treatment, I'll just think about it as two groups. So there's the anti-resorptive agent, so understanding the bone remodeling process. So knowing it's a balance between osteoclast activity and osteoblast activity. So a group of those drugs function more on the osteoclast side, and then a group on the osteoblast side. How many in the room prescribe their own osteoporotic medication, or rely on what is the OBGYN or endocrinologist or rheumatologist or to prescribe the medication? How many prescribe it themselves? Yeah. So when you think of, I'm not going to go into details about the mechanism of action of all these different medications, but if you look at the anti-resorptive agents, you see bisphosphonates, alendronate is the most commonly talked about. You have the Prolia, and these are all medications working towards the osteoclast side to inhibit bone resorption. And then on the anabolic agents, we have Forteo and Evenity, but Forteo has been studied quite a bit in not just reducing the risk for fractures, but also improving fusion for these patients after surgery. Evenity is a newer drug, less studied compared to Forteo with regards to adult spinal deformity, but it's also a drug I just recently operated a patient about 6 weeks ago on Evenity. So it's something but we don't have any very strong studies looking at its effects on patients undergoing deformity surgery. The reason I ask about prescribing this medication is that you have to understand that this medication is also, like everything we do, they come with potential side effects. So there's several things you have to do. You have to obtain labs. You have to send the patients for dental work. You have to discuss with your primary care physician about what is cardiovascular risk, risk for cancer. We know for patients with Forteo, I don't know how many people know this, but it's a relative contraindication for patients who've had radiation therapy because it can lead to osteosarcoma. I remember having to call one of the rheumatologists in my early practice because he had prescribed a patient Forteo, and when I called him, he was actually upset with me for calling him to discuss the treatment for the patient. And all I was trying to tell him is that he had prescribed the patient Forteo, and the patient had undergone extensive radiation therapy for his prostate cancer. And so these are things that we have to be aware of and sometimes guide the rheumatologist or the endocrinologist or even our metabolic bone clinic. I think it's an important part to have within the department to help manage these patients with osteoporosis. So the group out of Brown did a pretty good study, and they have this table that goes over the different medications I just mentioned in the previous slide. So if you want to take a picture of this, or you can, I'm sure we have the PowerPoint available. You can look at the different advantages and disadvantages and mechanism of actions of all these medications, and especially sharing this with your metabolic bone clinic specialists within your department or whoever you deal with, so they can understand how this directly impacts the surgeries you're doing, because it goes over what has been studied and the benefits in relationship to spinal deformity surgery. The next question is duration of treatment. Was the severity of the osteoporosis I mentioned was a cutoff? No one has really defined a cutoff for surgery for these patients. We all have our own, I think, anecdotal experience and cutoffs that we've decided we'll go by, but there's really no science behind when do I avoid surgery. What's the urgency for surgery? Can the surgery be delayed for months, a year, or 2 years to get better treatment of the osteoporosis before you proceed with surgery? What's the safety profile of the medication you've selected or your specialist has selected? And the response to treatment, do you get a repeat DEXA scan? Do you get a repeat CT scan to see how the quality of the bone has improved before you proceed with surgery? There's no consensus regarding timing. On average, if you look at some of the studies out there, shows between 6 to 12 months. But if you look at breaking it down by the anti-resorptive agents versus the anabolic agents, for the anti-resorptive agents, they seem to, based on studies out there, you only require maybe about 3 to 6 months before proceeding with surgery. And you can continue most of these medications through surgery and not stop them before or after surgery, as we do with certain medications. For the anabolic agents, the recommendation or evidence support may be treating for greater than 6 months before you proceed with surgery. And this is another table from the same study I showed you, looking at surgical planning. These are different things you can use as far as trying to determine how do I go about adjusting my treatment for this particular patient to reduce the risk for failure because of the osteoporosis. We've talked about age-adjusted alignment parameters, especially as we discuss mechanical failure, including PJK, which is a hot topic, or DJK if you're not fusing down to the pelvis. Fusion levels, do you stop within the upper thoracic spine or lower thoracic spine? Screws and hooks. If you look at the studies based for mechanical failure, looking at PJK, by far it's still level 3 evidence, but hooks have been shown to be most effective at reducing the risk for PJK. Using expandable screws to help get better fixation or better capture of the bone, and then using screw augmentation. Do you use cement? Do you use PMMA or calcium phosphate to help augment your screw to improve the binding of the screw to the bone? So this is the approach that I take when I see a patient who comes in with adult spine deformity. And this is based on all the literature that I've reviewed. So one is the patient a candidate for surgery? I think it's typically the first question. What options do I have? First, we always talk about non-operative options, injections, physical therapy. But now, if the patient has failed all of those, is the patient still a candidate for surgery? What are the medical comorbidities? And I'll go over 2 cases, and you see how we apply this towards those cases. Do they have a DEXA scan? As I mentioned, even if we go over everything and the patient decides they don't want surgery, I still make all the attempts to treat their osteoporosis because it reduces the risk for that patient's curve decompensating or that patient developing a fracture, which can now lead to surgery, and also just keep the patient healthy. Or the patient may end up being a surgical candidate a few years from now or a few months from now, and at least I'm ahead of the treatment before they ever require surgery. I typically do not get a CT scan unless the patient is planning for surgery. Or for some patients, you discuss surgery and they're thinking about it, and we know their bone quality is not great, and we need more information to make that decision. Then I'll get a CT scan, typically, deformity surgery, thoracic, lumbar spine into the pelvis. I'll get a CT of the thoracic and lumbar spine, and we can use that to have more information so we can make a final decision as to what we do next. Pre-treatment, I mentioned duration for treatment for osteoporosis. What's the urgency for surgery? Some of these patients come in and they have a neurologic, like impending spinal cord injury or severe radiculopathy and difficulty with activity of daily living and difficulty with their function. How do I optimize fixation? How do I decide the surgical approach? Do I do anterior alone, posterior, anterior, posterior? Do I include osteotomies to help correct without depending so much on the screws? We know this is screws I can pull out. So do you need to do osteotomies to help gradually correct the spine without having to depend on your screws and your rods to get your correction? How do you incorporate navigation and robotics into your surgery? I do most of my surgeries freehand, but I'm starting to, some of these patients with bad bone, incorporate navigation into the surgery. So one pass through the bone, and I can put a much larger screw than what the pedicle actually measures, because it's more accurate. At the end of the day, it's more accurate than freehand surgery. Consider less invasive procedures, and we'll go over a case that addresses that. So just to go over a couple of cases, here's a patient who presented to my clinic. I think I was maybe my first or second year in practice, with chronic, tolerable back pain, but she's presenting with severe bilateral lower extremity radiculopathy for several weeks. I have her x-rays because I've used this in other talks, but I don't have her MRI, given it's from my practice from over 9 years ago. Severe lumbar stenosis at L2-3, L3-4, and L4-5. And she's now wheelchair-bound for 3 weeks and presenting to my clinic with inability to walk, and she can't tolerate her life and feels something needs to be done. She has severe coronary artery disease and CHF with a pacemaker, and with untreated osteoporosis with a T-score of -3.3. Normal strength, positive straight leg raise in correlation with her radiculopathy. So her main issue is a radiculopathy and weakness and inability to walk. Here's a patient's x-ray. This is the x-ray I showed you guys at the beginning, showing the severe thoracolumbar curve, and you see significant CHF. Discussed this with her cardiologist, her primary care physician. As we talk about, it's not really a surgical clearance, it's a risk stratification. So they think the patient can proceed with surgery, but she's a very high risk for coronary incident during surgery. So I discussed this with the patient. Her T-score is pretty bad. She's untreated osteoporosis. I remember this case because I sent it to one of my mentors from fellowship at NYU. I sent it to one of our faculty from fellowship who dealt mostly with MIS procedures and DGen procedures. And he responded. I think that was the fastest response. I think he responded. I sent him a PowerPoint, and he responded within maybe 10 minutes and said, "Why are you sending this to me? Send this to Frank Schwab. He can tell you more about deformity since we train with Dr. Schwab." I was like, "Well, I'm sending it to you for a reason. I want you to think outside of the box, because I'm thinking about just decompressing this patient without fusing the patient because they have poor bone. It's not a healthy patient. I'm trying to minimize the amount of surgery." And he took a look at it. It's like, still talk to Schwab about it. So I called Frank Schwab and I spoke to Kyle Kabesh, who was my mentor from residency, to get the opinion. We talked about this for quite a while, and I decided to take the risk and do strictly a decompression instead of doing a big deformity surgery on this patient, and did an hour-and-a-half procedure, decompression alone. And the patient is 9 years out now, pain-free and walking around. Because she told me, I know I have scoliosis, it doesn't bother me. The issue is my leg pain, and I can't walk, and I've been wheelchair-bound for 3 weeks. So for some of these patients, that's all you need to do. And I have quite a few patients like this that I've done strictly decompression, and they're years out from surgery and doing great. It doesn't mean they don't carry the risk for decompensating, but at least we buy some more time, and hopefully you can start treating the osteoporosis if they ever need more surgery. None of us like doing revision surgery, but sometimes that's what we have to do, and we take on the challenge and do it. And that's what I try to explain to some of these patients. I'll do a laminotomy instead of a full laminectomy and do central decompression. And if it fails, I'm the one dealing with a revision surgery. I don't mind doing revision surgery as much as I don't like doing them, but we deal with it, and patients still do well. So next patient, I think this is a patient I just finished going over. So coronary artery disease. So we'll go to the next patient. This patient presented with back pain, hardware failure, radiculopathy, and weakness. So 75-year-old female with spondylolisthesis at L5-S1, lumbar stenosis with radiculopathy. She sustained a fall 13 months prior. Saw one of my senior partners. I just did surgery to this patient, I think, a month ago, with difficulty with sleep and ADLs due to her pain. She has underlying Addison's disease on chronic steroid with a T-score of -3.5. And history of a CD construct, so Cottrell-Debussy construct, which is hooks and rods, no screws, performed in the 90s. Strength, she has 5 out of 5 strength, except S1. As you can see, I'll pull up the x-ray. You see she has a fracture at this level. On the CT scan, she has a vacuum disc at T10-11, indicating non-union, and you can also see posteriorly there was no evidence of fusion across that site, which will likely explain why she fractured, even though she sustained a fall. The rod has slightly migrated, and this rod is directly on top of the S1 nerve and into the canal. So even one of my concerns going into the surgery is that as soon as I take out that rod, it will be CSF all over the place, and it's directly, and the pedicle at S1 is also destroyed. So this patient is walking around with a Trendelenburg gait, severe leg pain. We sent her for injections, medications, and nothing seems to be working. I referred her to our metabolic bone clinic for evaluation for osteoporosis while we continue with the workup, and I'll go over a few of her scans here. So this is a CT scan. You see the top of the construct looks great. This is stainless steel, so that's why we didn't get an MRI, so we got a CT myelogram instead. So the top of the construct, and you can see the pseudoarthrosis right on the far right image there, or far left, showing the vacuum disc at T1011. And this is going down into the lumbar spine. As you get right here at about L45, you start seeing the stenosis with the CT myelogram, severe stenosis at that level. And as you get down, you see the rod is sitting directly on top of, right in the lateral recess on top of the S1 nerve root, and which correlates with her hip abductor weakness. We know most of the time it's L5, but S1 can also supply your hip abductors and cause Trendelenburg gait. And measuring the Hounsfield unit, as you can see, she has a mean right at this level where you see some sclerosis in the bone is up to about 299 at the L5 level. But on the other side, as you go within the vertebral body, is 66. So quite significant osteoporosis. And this is measuring the Hounsfield unit at L4, measuring at 83. And just measuring at different levels. So what are the options? Do you treat a non-op? She's developing severe pain, difficulty walking.
May I have your attention, please? May I have your attention, please? We are currently testing Philip's fire alarm system. Please disregard any audio or visual devices at this time. We're resolving a test. Wow.
So we discussed non-operative management, and given her current status, she would like to consider something more. Okay, so my senior partner who referred her to me, we discussed removing all of the hardware, so it gives her at least a chance to get MRIs in the future without any artifact, and revising the patient from T3 or T2 down to the pelvis, wherever we can get good fixation. I also, actually onto the day before surgery, given her osteoporosis, and the morning of surgery, I made the decision actually standing in the operating room and pulling up her images. I'm not taking out the top hardware. Because she has very poor bone. We know she has good fixation at the top, even though it's stainless steel. If I take that out and I put screws at T1, T2, and that fails, then I'm screwed. I'm going up to the occiput, or going somewhere into her cervical spine and possibly down the road to the occiput. So that was an option, and then I'd also considered doing inner bodies at L4-5 and L5-S1. And I go through the same algorithm that I go through when I look at this patient. So she has Addison's disease, chronic steroid, as I mentioned, untreated osteoporosis. Recently prescribed Forteo she underwent the workup with one of our partners who manages the metabolic bone clinic, and was prescribed Forteo but had not picked up the prescription. This was actually finally delivered while she was in the hospital, and started treatment after her surgery. Radiculopathy, left buttock weakness, Trendelenburg gait. I decided to incorporate navigation into this, even though, yes, with these patients with previous hardware, you can use fluoroscopy on the AP and find the patacore and get a good screw in there. But I decided to use navigation because I wanted to put larger screws than what I measured on the CT scan. And there's good evidence to support use of BMP on these patients with osteoporosis. BMP actually improves fusion. And in this case, too, luckily, she was a candidate for Forteo, which also we know helps with fusion. And as I mentioned, doing partial removal of the hardware versus complete removal. So I took her to surgery, and now it's about maybe a month ago, and resected the rod and gently removed the hooks, making sure in trying to remove that rod, especially on the left side, not to push it further into the dura. And luckily, the rod came out, no dura leak, no complications. And then extended the patient down into the pelvis, and then fixation around the previous CD construct. So fixation over a T8. I think T8 was pretty much put in screw and butter. Completely, like no bone at all, but T9 had some fixation, T10 had some fixation. And then we used side connectors to connect the rod to her previous CD construct. And that was her pre-op and post-op. Thank you.
start off with a question. I think you brought up a great point about when we're revising these old constructs, you know, I call it double jeopardy proximally when you, you know, don't think about it, there's nothing going on proximally, and you still fillet open and re-damage or re-injure those muscles up top, and then all of a sudden they have PJK. So I think that's a great take-home point for everybody.
Yeah. No, thank you. No, I think it's something, you know, sometimes we think we can go in there and fix everything, but sometimes we just accept part of what is there already. If you look at the literature supporting fixation for PJKs using hooks, right? She already has hooks. There's no failure at the top. She had that slight shoulder asymmetry, but she was doing just fine. Yeah.
We have an activation of our fire alarm system. Please evacuate to the ground floor.
I'm sorry? Yeah, so you can consider that if you look at the previous studies, the short-term studies from Kibesh looking at using cement augmentation at the UIV, so the upper instrumented vertebrae, and even 1 and 2 levels above, it showed a reduction in PJK with a 2 years follow-up. But the long-term follow-up, which is up to 6 to 7 years, actually showed no difference. So there's still a significant risk for, yes, if I revise the patient higher, I try now more to put a larger screw than using dependent solely on cement. But that's certainly an option, but understanding it's not foolproof. Yeah.
So, talking about patients with osteoporosis, in the pre-treatment of when you define them to be osteoporosis, when do you begin treatment to when you actually have treatment for osteoporosis and when you take the surgery? Say you have this kind of treatment minus 4. Do you just have to start treatment and, you know, fix them up? What's your guidelines?
You said negative 4 point. Oh, I was about to say negative 4.4. I'm trying to avoid surgery at all costs. So in this case, like we say, your hands can be tied sometimes, right? Depending on what the patient is, what's the urgency for surgery. Majority of the time, it's an elective procedure, right? So we can wait. But sometimes these patients present with neurologic deficits, and you have to make a decision. But I still do my best, like between seeing this patient for the first time and getting the patient started on osteoporotic medication, I think all of that happened within a month and a half. Because I was able to, I contacted my colleague. It's not one of those where you say, go see this person. I called him and said, I need this patient started on something as soon as possible. And how you dictate your note to make sure the insurance approves it. You have to dictate the urgency of what you're doing so that way insurance can get something started as soon as possible. But if you look at the studies, it says about on average about 6 to 12 months. But with the anti-resorptive agents, it says it's probably safe within 3 to 6 months, and with the anabolics agent, greater than 6 months. Thank you.